Most of these slides were exceptional, just for experts a little bit. I have no idea who is dealing with skin lesions, ulcers, burns, and all this stuff. Okay, some do. This is a large field, which will become in the market within the next 1 or 2 years. You've seen the picture, and you can see the picture and all these exceptional indications on the ISMST website. Osteochondritis dissecans, Osgood-Schlatter, Peyronie's disease, spasticities. Peyronie's disease I've been in Asia for lecturing, and there's 20% of the audience are dealing with shockwaves and Peyronie's disease.
It's a big problem there.
I can't even hear the question. So anyway, this is a case where a swimmer was hit by a boat, has a large wound defect, not able to get surgery because diabetes, infection, all this stuff, and the patient got shockwave treatment, and it healed. Even this is the case with an overweight patient with a chronic ulcer, diabetes, necrotic, infected ulcer, with an AV shunt, and all the stuff is done. No better perfusion was able to do. Shockwave treatment was performed, and you can see after 3 months, this severe case has found to be healed within this interval of 3 months, with many months and years of painful ulcers with no options. These data right now, the question.
Sorry, what you cover it with how is the treatment actually done?
How do the technique? Every clinic has certain setup to deal with chronic ulcers or wound diseases. Wet dressings, dry to dry, all this stuff. We don't change the technique the clinics are doing. In my office, we do wet to wet to treat these skin lesions. The patient come in, we clean the wound. We remove the wound dressings, we clean the wound with water, just water, and we put some sterile foil on it, with gel on it, and through that foil we do the treatment. After treatment, removing, cleaning the wound, sterile dressing on it, wet to wet. So we do it once a week. This is our setup. And we're doing 500 shots per square centimeter. So if I have a large defect, so we're treating the whole area.
That takes a long time, right? 500 shots, if it's a large lesion.
If it's large lesion, it needs time, for sure, it needs time. And what my personal experience is that the border of the ulcer is the region where you can treat most successfully. Right. The growing phase, the closing normally comes from the border down to the center. But we have also cases when we have some cell change, we have skin cells appear in the middle of the ground of the ulcer. Normally they don't appear. Normally we never have appearance of skin in the middle of the ulcer. It just came from the border. We have some cases where we have skin appearance in the middle, and the skin closes from the middle also. So this will be a large indication field for the next years. So it's used in chronic ulcer, in burns, and all this stuff because we know we have a neovascularization, vasculogenic factors. We have all these biomechanical properties. This is a red flap model. Again, this is a radial technique, and you see how we performed it. You see how we performed the flap preparation. The whole skin was dissected, the artery was dissected. Then we did the treatment. One group gets 300 shots with radial technique, and one group gets 600 shots. So still an animal model. And one group just gets placebo treatment. We did the laser Doppler imaging system, which is a good system to analyze the perfusion of the skin. And you can see in the active group that the blood perfusion, and with regard to ischemic area, the control group is doing worse. So as much shockwave were applied, as better the blood perfusion of the necrotic area is, even in the borderline area. That's the reason why we start the treatment for chronic ulcers at the border of these ulcers. The size of the vital area, it's bigger in the active group, 600 shots with radial technique, 500 shots per square centimeters. And the size with regard to the ischemic area is decreased in the active group with 600 shots, statistically significant in comparison to the 300 shot group and the control group. Shrinkage, it's everybody who deals with burns, for example, knows that shrinkage of the scar, it's a main issue to deal with. And if the patient got shockwave treatment, the percentage of shrinkage is decreased as well. So healing phase and healing speed is accelerated, and the shrinkage percentage is decreased when they get shockwave treatment. The radio technique is also appropriate to use in chronic ulcers and burns as well if you have skin lesions. This is from Wolfgang Schaden. You see prospective trials, not placebo-controlled, with all these ulcers because of trauma, surgery, venous disorders, artery perfusion disorders, defibrillated burns and stuff. And he applied 500 shots per square centimeters as well. You see these ulcers, nobody wants to have it. And in the group of burns, for example, 5 cases, all they healed with shockwave treatment. With chronic venous ulcers, they mostly healed by shockwave treatment. And we found in our group that even an affected area is no longer a contraindication. We did a study with microbiological setup using some bacteria stains. We dealt with the special holder. We placed the bacteria in certain water bars area. We put the patient in the focus, we put the bacteria in the focus, apply 4,000 shots with different energy levels, up to 0.96 millijoule per square millimeters. You see these bacteria stains. Everybody who does surgery knows the names precisely, immediately, and nobody wants to have these kinds of stains in your chronic ulcers. That's the outcome. You see the gray lines is the control group, and these lines over down, these are the active group. Even if you have an MRSA, it's very effective. It's a logarithmic scale, so the number of bacteria is significantly decreased in all bacterial stains. There's a relationship between the energy flux density, as high the energy flux density is, as less bacterial concentration is. Also with regard to numbers of impulses, as much numbers were applied, as less, as much bacteria were decreased in numbers. So there might be